for joining us and welcome to this evening's Smilow Shares event. We have really some great panelists here whom a lot of you I'm sure know. And we're going to just be talking about to patients, talking to some doctors on here. There's all sorts of people here, advocacy groups, there's administrators, there's a whole array of people. So we're going to try and target it to a bit of information for everybody. But obviously this is a lot for the patients as well, and probably a lot of patients on here. So I'm going to start with sharing my screen and just get started here. So today, we are talking about head and neck cancers. My name is Saral Mehra. I'm a head and neck surgeon at Yale, for those who I don't know. And we're going to be talking about new treatment advances and patient care in general. I wanted to start with just a little bit of an introduction, looking at a few things that you might find interesting. Head and neck cancer, not in the throat. We were doing pretty well for years. Things were going down. Things were going down pretty well, maybe due to less smoking and drinking. We're not sure, but one thing for sure is oral pharynx cancer, the back of the throat, has been going up in the last 10 to 20 years. A lot of this is due to HPV, an epidemic in this country right now. So I have a question for some of the patients here, are patients who are survivors of oral pharynx cancers or currently being treated or in some way being affected by HPV-associated oropharynx cancer. We hear a lot about HPV-associated cervical cancer, but my question to you all, see if you know the answer, is what's more common in this country, HPV-associated cervical cancer or HPV-associated oropharynx cancer? Think about that for a second. The answer is oropharynx cancer. A few years ago, it surpassed cervical cancer as the most common HPV-associated cancer. This is recent data accessed just a couple weeks ago from the CDC. So you can see cancers in the back of the throat have surpassed cervical cancer for HPV-associated cancers. We can probably thank a lot of this to screening and vaccines. So related to that, what percentage of adolescents aged 13 to 17 in the USA are HPV vaccine up to date? Think about that for a moment. Well, the answer is in Connecticut, there are about half of females and males are up to date on vaccines in this country, and that's in the state, and it's about the same as in the country. So we can talk about that more a little bit later. But what I wanted to do now was introduce our panelists. We have three great panelists here. Dr. Bhatia is our first panelist, and she is assistant professor of medicine and medical oncology here at Yale. And she will be talking about decreasing treatment intensity for HPV-driven head and neck cancers. And then we have Dr. Avanti Verma, assistant professor of surgery in otolaryngology, and she'll be talking about minimally invasive surgery in head and neck cancer. And our final panelist who will be speaking today will be Dave Zirlen, who will be speaking about swallowing rehabilitation and speech treatment during head and neck cancer treatment. And we have the famous Dr. Barbara Burtness as a panelist as well, available to answer questions and chime in. So please post questions to the chat. I'll moderate and I'll direct the questions to the right people. So without further ado, let's get started with Dr. Bhatia.
Am I heard okay? Okay, good evening, everyone. It's very nice to see a lot of familiar names. And thank you for the opportunity to present here today, Saral. In today's talk, I will be reviewing a special category of head and neck cancers, which are driven by the human papillomavirus. And we'll talk about different treatment approaches that have been studied recently in clinical trials in this subgroup of patients. So the head and neck is a tight-knit structure, but it's got many clearly demarcated sites, and it's important to know where a tumor is originating within the head and neck because treatment decisions are guided by the site of the primary tumor. And treatment plans are best made in a multidisciplinary fashion. Here at Yale, all of you have probably heard us talk about tumor boards, where we have surgeons, radiation oncologists, medical oncologists, speech therapists, everyone attending and chiming in to find the best treatment option for patients. And the goal of these tumor boards is not just to maximize the chance of cure, but it's also to preserve maximal function of critical structures like the tongue and the vocal cords. So about 70,000 cases of head and neck cancers are diagnosed every year, and almost 85% of these are diagnosed as local regional disease. So either with a tumor in the mucosa with or without neck nodes. And cure and survival rates for our patients depend not just on the stage of diagnosis, like earlier stage will typically do better than later stage, but also on just the extent of neck adenopathy, just neck nodes that are involved. And overall 5-year cure rates for our patients are about 60 to 65%, but it's much higher for HPV-associated disease. Some of the common risk factors that predispose people to developing a head and neck cancer include smoking, alcohol, and viruses, importantly, like the human papillomavirus and the Epstein-Barr virus, which is endemic in Asia. HPV-associated oropharyngeal cancers are on the rise in the West. It's epidemic proportions like we heard about. And they now make up almost 70% of all cancers, which are involving the tongue base and the tonsils. Tobacco use has been declining across the United States since the mid to late 20th century. And this trend has coincided with the decreased incidence of tobacco-associated malignancies, including of the lung and the head and neck. But although smoking-related cancers are on the decline, the overall incidence of head and neck cancers is slowly rising, and that's fueled by an increase in HPV-related malignancies, as we see here. So over the years, like if you compare from the 1990s to 2000s and 2010s, just the overall incidence of HPV-associated cancers has been on a significant rise. So what is the human papillomavirus? We hear about it a lot in reference to cervical cancers, head and neck cancers, and even anal and genital cancers. It's a sexually transmitted DNA virus with hundreds of different strains, some responsible for causing benign warts, and some high-risk genotypes like 16 and 18, which cause cancers in the cervix and the head and neck. HPV 16 and 18 account for almost 95% of all malignancies in the United States. The incidence and prevalence of this virus is rising in both men and women worldwide, with the majority clearing the virus within a couple years. But it's the ones who don't and have a prolonged latency period with the virus that are at risk of forming a virus-driven cancer. Men are more likely to develop this cancer than women and present at younger ages. The good news, though, is that we have an FDA-approved vaccine that protects against 9 strains of the virus, the most commonly infecting strains, including 6 and 11, which causes benign warts, and 16 and 18. It's given as a 2-dose series, 6 to 12 months apart, and people anywhere from age 9 to age 45 are eligible to get the vaccine. And what does the HPV virus do? So once it enters a cell, it takes over the host, the cell's cell division machinery. It disrupts multiple cellular and signaling pathways and prevents normal cell death to maintain the infected cells in just an alive, constantly dividing state. The most common proteins that the cancer makes, that the virus makes to promote cancer formation is E6 and E7. E7 interacts with a tumor suppressing gene called RB, which under normal circumstances just controls the rate of cell division. So inactivation of that RB protein allows the cells to keep dividing without any checks. And E6 is the other oncoprotein that inactivates P53, which is another tumor suppressor protein, which under normal circumstances controls cell death. So by inactivating P53, the cell is allowed to divide and then not allowed to die. So cells are basically immortalized. They just keep living And that just facilitates cancer formation later on. The observation that patients with HPV-driven cancers do better than HPV-negative cancers came from multiple older clinical trials, which graphed patients' cancer-free and overall survival by their HPV status. So this graph on the left shows that patients with HPV-positive cancers had better survival. So the top curve reflects better survival and also better cancer-free survival. So overall and cancer-free survival. And these two curves represent P16 status. So P16 is like a surrogate for HPV status in a tumor. And we frequently utilize it to test tumor biopsies to detect if HPV is present in the tumor or not. And curves that were graphed by P16 status showed the same results. So whether you're P16 positive or HPV positive, you tend to live longer and cancer-free longer than patients who are HPV negative. In the right chart, these patients were classified as low, intermediate, and high risk based on clinical risk factors like tumor and lymph node size, smoking status, and HPV status. And patients with smaller tumors, less smoking exposure, and HPV positive disease did the best, with three-year cure rates that were upwards of 90%. The usual treatment approaches that we use in head and neck cancers include either upfront surgery followed by adjuvant radiation or post-op radiation with or without chemotherapy. Treatment that's given after surgery is called adjuvant treatment. Alternatively, we will also sometimes use chemoradiation concurrently, so upfront chemoradiation without initial surgery to cure the patient and spare the removal of organs like the back of the tongue. And sometimes we use chemotherapy before radiation or surgery to shrink the tumor and make it more amenable to resection or radiation. And this is called neoadjuvant or induction chemo. And patients experience many side effects, mucositis, weight loss during treatment. These will typically improve within a few weeks after treatment, but there's also many long-term side effects that can persist many years and sometimes even lifelong. And broadly, these are categorized like disorders of chewing and eating, which is caused by trismus or narrowing of the mouth opening, dry mouth, difficulty swallowing, dental issues like predisposition to caries, periodontal atrophy, necrosis of the jaw, difficulty with neck and shoulder range of motion, which can be caused by scarring, lymphedema, vascular bleeding issues, and chemo-related side effects like hearing loss, ringing sounds or tinnitus, kidney damage, and nerve damage. So to minimize these impacts on patient quality of life, a lot of research and several clinical trials over the past few years have focused on safely decreasing treatment intensity in patients with HPV positive cancers because they do better. And at Yale, we've participated and led many of these studies. So surgery in the past, when it was utilized for these patients, involved, splitting open the jaw to gain access to the back of the throat to remove tumors in that area. We now have transoral robotic surgery, which is minimally invasive, much less morbid, and decreases the impact on speech and swallow function, has a much less length of stay in the hospital after surgery. And Dr. Verma will be talking more about this in the next segment. The other treatment approach that we very frequently use is concurrent chemoradiation, like we talked about, either by itself or following surgery. When utilized by itself, we call it definitive or upfront chemoradiation, which is given over 7 weeks with 70 gray of radiation and 7 weeks of cisplatin. When it's given after surgery, it's called adjuvant, like we talked about, and it's usually given over 6 weeks with 60 gray of radiation and 6 weeks of cisplatin. Cure rates with this treatment approach are upwards of 80 to 90% for most early stage HPV positive patients. And clinical trials have looked at different ways to get away from these hefty doses of radiation and even from cisplatin, which has a lot of long-term side effects. So for instance, some trials have explored initial induction chemo and then followed it up with lower doses of radiation for patients who respond to induction. And the radiation doses that have been looked at have been as low as 45 gray with this approach instead of 70 gray. And some other trials have tested combination 6 weeks of radiation and 60 gray of 6 weeks of 60 gray radiation and 6 weeks of cisplatin instead of 7 weeks of both. In the adjuvant or postoperative setting, multiple trials have tested lower radiation doses, so 50 gray, 45 gray, 30 to 36 gray even, in combination with cisplatin and non-cisplatin chemo as well. Most of these trials are still monitoring their patients for disease recurrence and cancer-free and overall survival, so the data needs to mature, and none of this is standard treatment yet. All of this is being looked at in the clinical trial setting. So our goal for the future, is to keep designing and conducting safe and effective trials that will test better tolerated treatments and newer treatments without compromising cure rates. We also need to better understand which patients can be safely de-escalated and which need to get the standard treatment for best outcomes. Over time, we're hopeful that these efforts will give us uniform national consensus-based guidelines to help improve the lives of our patients. That's really the end goal of all these efforts. And that's all I have. Thank you for your attention, and I'm happy to take any questions.
That is a great overview of HPV-associated oropharynx cancer. Thank you, Dr. Bhatia. There are some questions. Some people are just messaging me directly. Some people might be embarrassed to put into the chat. But I have some questions that are coming in. You talked at the end about less treatment. Which patients are eligible for less treatment, and how do you decide who can get less than the standard treatment?
So based on the experience we've had, just retrospective, looking at which patients do best with HPV positive cancers and which are still high risk, we go by multiple clinical and just radiographic features. So, for instance, if you've had not much of a smoking history, less than 10 pack years, you're considered lower risk. If you have ipsilateral neck disease, meaning the nodes are on the same side as the tumor, not too many nodes, not bulky nodes or big size nodes. So single node or one or two small nodes, those patients tend to do best. Patients who have well lateralized tumors, so without extending to the opposite side, tend to do better. So smaller tumors, smaller neck disease, lower smoking exposure, in general tend to do better with less intense treatment.
Great. And then a question for Dr. Burtness. I'm going to pivot to her since we have her expertise as well. I know you and her work together hand in hand so well together. But clinical trials, Dr. Bhatia did speak about clinical trials and talked about Yale's role in clinical trials. Can you speak to how do you decide who can enter a clinical trial, and what are the benefits of clinical trials?
Thank you for the question, Saral, and great talk, Aarti. Really great to listen to you review that. So, I would say our interest is always in offering patients not only the best treatments that currently exist, but making sure we explore what's on the horizon for them. And so, like you were just hearing, if the existing treatment cures 92% of everybody who gets it, we aren't necessarily looking for, a whole big revolution in that kind of therapy. We aren't looking to put that kind of a high cure rate at risk. But if we can identify that treatment can be, too lengthy or too uncomfortable or leave people with long-term side effects, then what are the rational steps that we could do to try to decrease that? Now, on the other hand, if we have patients whose tumors are very deeply invasive into the base of the tongue, or who have bulky lymph node involvement, particularly in the setting of a long prior history of smoking, that's a group of patients where the cure rate is not as high. And so a trial that we have for those patients at the moment involves giving them standard of care and then exploring whether or not immunotherapy after the radiation can bring about a higher cure rate. There are different situations where patients' cancer may have come back and not be amenable to surgery and radiation anymore. And there again, we have quite good standard treatments, but they may not be suitable for everybody, or there may be patients where those treatments stop working. And then it's a completely different kind of clinical trial where we're looking at all new drugs that we hope are really going to be a whole lot better than what currently exists. So I think our posture is always we want to think about what clinical trials might be out there for a given patient, and then think through with the patient and their family, is this a good fit or not?
Great. And then a follow-up to that, Dr. Burton, is are there clinical trials just for HPV, or are there trials also for non-HPV associated cancers?
There are trials just for HPV associated cancer, and really at all of the stages that we've just been talking about. I can tell you that when we proposed the very first trial like this in 2008, it was seen as so unlikely that we could actually complete it, that after it had all been approved, the National Cancer Institute put it on hold, and we had to go down to Bethesda and like do special pleading to get it off the ground. So there was a time when the idea that you might manage HPV associated cancer differently or uniquely, or think about deintensification, was really controversial. And now it's very widespread, and they're big national studies.
Got it. But you do have trials for cancers that are not HPV associated here at Yale as well, right? I see some larynx cancer patients, oral cancer, sinus. You have some of those as well, correct? Yeah. Great. And then Dr. Bhatia, I have one last question before we move on to Dr. Verma. What is the definition of cure? One of our patients asked. Is it stable disease at 5 years or some other measure? How do you say a patient is cured?
So when they're diagnosed and they have a tumor and neck nodes, ideally with any sort of treatment, with surgery or with chemoradiation or both, we're looking for that tumor to shrink and be gone, right? So we don't expect to see any tumor there after treatment. We don't expect to see any neck nodes. If there's any remaining, we deal with it. We biopsy or we remove whatever remains. So the goal is to be in remission. And typically, the duration of that is about 5 years. So we closely monitor patients for the first couple years in a multimodality fashion with different teams participating in surveillance. Then we space out the surveillance a bit more, but usually we're seeing them very closely for the first 5 years.
Right. So no evidence of disease up to about 5 years, we typically will call you cured. Great. Okay, so now we're going to move on to a different modality of treatment. So we heard from Dr. Bhatia, one of our great medical oncologists in head and neck, and now Dr. Verma is going to speak about minimally invasive surgical options for patients with head and neck cancer.
Good evening, everyone. It's really a pleasure to be here and to see so many of our patients on the call. I'm also very appreciative to Dr. Bhatia for giving a great introduction to HPV-related carcinoma, because I think I'm going to jump right into some of the technical aspects and considerations we have when we talk about minimally invasive head and neck surgery. I will focus on robotic surgery because it's one of our great techniques to de-intensify treatment of patients with HPV-related or oropharyngeal squamous cell carcinoma, but there's some other things that are that I'll discuss as well. Okay, so in general, the principles of head and neck cancer surgery involve the surgeon being able to visualize the tumor, but also the entire surgical field and the normal tissue surrounding the tumor. And we prefer to resect the entire tumor and get negative margins, which means that, I often tell patients in the clinic too, that we take some normal tissue around, all around the tumor, and make sure at the time of surgery that all those margins are clear and free of cancer. At the same time, though, as we'll see, the head and neck is a very concise area of the body where there's a lot of important functions that happen. And so we try to preserve surrounding structures as much as possible. So I know we've seen some slides of head and neck anatomy. Within the head and neck, there's many sites. And I know our patients on today have had cancers of various different sites, starting from the oral cavity and going back to what we've been sort of talking about so far, the oropharynx, which is the back of the tongue and the tonsils, but also the soft palate and the wall at the back of the pharynx as well. So that can continue down into the voice box as well, where the larynx is and your vocal cords are. And I have the whole list there. We also, often talk about surgery involving of the neck because of lymph nodes that can be commonly involved with cancers in these areas. Within the neck, though, there's many structures that we identify and preserve. Blood vessels, there's lymphatic channels often that we are finding in the neck, nerves, muscles, all important for function. And then even the bone, the jawbone or the bone of the upper jaw or the maxilla, and cartilage as well. The cartilage that surrounds your vocal cords is also something we consider. So the two main minimally invasive approaches that I'll discuss are robotic surgery, and there's a photo of that setup on the left-hand side, and then laser surgery on the right-hand side. Robotic surgery is really used most often in the oropharynx, which is what we have been talking about, particularly for HPV-related tumors in the back of the throat. It can also be used for the supraglottic larynx, which is the part of your larynx that's above your vocal cords. Laser surgery has existed a bit longer. I would say robotic surgery was really first used in the head and neck region in the early 2000s. Laser surgery has been around for a few more decades, and now it can be used for the oropharynx, and it had been in the past, but now I would say that it's primarily used in the supraglottic larynx and the larynx, and particularly the vocal cords, and it can also be used beyond the vocal cords in the trachea. So looking at the setup for the transoral robotic surgery, what we also call TORS, which is short for that. These are photos of one of the older models of the robot that we used. And on the left-hand side, you can see that there's several arms, and all the arms are sort of at a particular angle. So each arm sort of moves around that vector. In the center, typically there's a camera, and you can see that on the right-hand side where you see that the patient's mouth is open, there's a retractor in there, and the middle arm, the one that's bigger, is the camera that allows us to see, and then the two arms on the side are instruments that we use. One instrument typically is an instrument that allows us to retract, and the other one is sort of a powered instrument that allows us to cut, but also minimize bleeding during the time of surgery. And going back to the left-hand side, there's an assistant that's always with the patient and checking to make sure everything's okay. And then the surgeon is actually in the same room, because I've been asked whether the surgeon's in a different room, and typically they're in the same room and they're at the console, as we say, controlling the robotic arms, all aspects of it, zooming in, zooming out, and controlling each of the instruments. Now, this is the newest model of the robot that is FDA approved for head and neck surgery, and it's called the single port robot. And on the left-hand side, you can see that it's just one port, and the different arms come out of that one port, and they're very flexible. And so on the right-hand side, you get a closer view. This is a photo I took actually while using the robot just to practice on some things. And the camera flexes too and is very flexible, and then even the arms are as well. So this allows us an even greater access of ability and flexibility to see the tumor, the area surrounding the tumor, and also use these arms to remove it. So now getting back to when we use it, I mentioned before that we can use it for early stage oropharyngeal cancers, particularly those that are HPV related. And so that includes the tonsil, the base of the tongue, sometimes the soft palate, and the pharynx, which is the wall sort of at the back. So if you look at the top right-hand corner, this is the view that the assistant sees and the surgeon sees before going to the console to start the surgery. The patient's jaw is sort of at the top of the screen and the head is at the bottom of the screen. So things are a little upside down, but we're used to working that way. And you see the back of the tongue on the right side and the left side, that epiglottis that's right in the middle between the two. And then this diagram points out the tonsil cancer, which is small on the right-hand side, and then the uvula, which is up towards the head. And in the left-hand side of the screen, you can see one of our little instruments. It's a grasper instrument. And then the bottom photo is actually a photo of mine where I orient the tumor in the same way as it came out of the patient. You can see that uvula there, and I try to describe all the margins for the pathologist so that they can take slices at each side and make sure that the margins are negative. So to go back to the left side of the slide, transoral robotic surgery or TORS can also be used for early stage supraglottic cancers. Sometimes it's used for benign tumors in these same locations as well. And even some deeper tumors that are just beyond the throat into the deeper tissues of the neck. Sometimes in very select cases, it can be used for that too. And some surgeons even use it for sleep apnea. So when we evaluate a patient for transoral robotic surgery, there's a lot of factors we have to consider. I mentioned before that we consider this particularly for the early stage cancers. So the size does matter. Generally, smaller tumors are more favorable. The location also matters. Dr. Bhatia mentioned that lateralized tumors often have a favorable prognosis and are, more potential for de-escalation of treatment. So, again, for surgery, lateralized tumors are much more favorable than ones that exist towards the midline. One of the reasons for that is there's two arteries that, particularly with the tongue base, that give blood supply to the tongue. So we want to make sure that if one side is completely clear, we don't risk both the vessels and the blood supply there. And the depth of the tumor matters too. If some of the deep muscles of the tongue are involved, that may, first of all, indicate a higher stage, but also be a sign that if we do surgery, there may be some long-term swallowing dysfunction as well. Mouth opening is very important because we have to be able to get the instruments inside. The single port does help, but even beyond the port, the instruments need some room to move and avoid collisions and things like that, which can happen with the teeth or the jaw. And that's the next thing I said, the status of the teeth and jaw. So making sure that the jaw is healthy, that we don't have any loose or unhealthy teeth that might be risked by this surgery. And then neck mobility matters as well, because you can see in this photo, the patient's neck is slightly extended. So if someone has a history of surgery of the spine or cannot be extended like that, that might be something that might be difficult to manage during surgery, so we can get good exposure. So the benefits of TORS is, it's minimally invasive, so we avoid the maximally invasive approaches that were traditionally used prior to the advent of this technique. And that was splitting the jawbone and going back to the throat that way. And usually when we did that approach as surgeons, patients would develop swelling, and we would usually perform a tracheostomy tube placement as well at the time of surgery, so that patients can breathe after surgery and then eventually have that tube removed. But that does require a longer hospital stay and longer rehabilitation. So again, the benefit of transoral robotic surgery is that there is a faster rehabilitation, and the hospital stay is generally shorter. And it's a way that we could potentially reduce or de-intensify patients in terms of needing post-operative treatment, including radiation and therapy and chemotherapy. Now, there are risks of this kind of approach as well. As you might have seen in the previous slides and photos, we do put retractors in the mouth to be able to see, and some of these retractors, are pressing against the tongue during the surgery. We try to give patients a break during the surgery as much as we can, but sometimes when the tongue, is retracted for a period of time, it can cause taste disturbance. It can cause tongue numbness as well. There can be problems with swallowing, but what we've seen is that patients do tend to recover from the initial effects relatively quickly in general. And then velopharyngeal insufficiency is a technical term for if there is a resection of the soft palate, if that palate doesn't meet the back of your nose, and sometimes if that doesn't happen, then it can cause either airflow from the nose, changing the quality of speech, or even regurgitation of liquids from the nose when you're trying to drink something. If we think that might be an issue based on where the tumor is located, we often don't recommend the surgery, but it is something that could happen if if the soft palate is not able to close against the back of the nose. Another risk is sometimes when we perform this kind of surgery with the neck dissection for the lymph nodes in the neck at the same time, there is a potential to create a connection between the mouth and the neck. There are ways we can do, there are things we can do to sort of minimize that connection or close it off, but that can become apparent after surgery. And that's why we watch the drain that gets put in the neck very closely after surgery. What has been discovered over time, and this is probably the most feared complication of surgery, is bleeding after surgery. It doesn't necessarily happen right away. I think the highest risk period can even be 7 to 10 days afterwards. But you know, that there's arteries and major vessels that could be in the back of the tongue and near the tonsils. So what we do now, which is the standard of care, is that, you know, if we do a neck dissection either before this transoral robotic surgery or at the same time, the same trip to the operating room, we'll actually find the external carotid artery branches, if not the terminal branch itself, and make sure that we ligate it to minimize blood flow to the area that may cause bleeding like this. So we've definitely seen less of that. So that now I'm moving on to transoral laser microsurgery, which has been around a bit longer. And this is sort of the photo of the setup. On the left side, these are the instruments that we need, particularly if you look at that green table on the lower left corner, those are the instruments we use in the mouth to get exposure. Typically, like I said before, this is the area just above the voice box or at the vocal cords themselves. And we use those instruments to get exposure. The long metal rods are our telescopes so that we can really look up close. And then there's graspers and other instruments on the right-hand side. So there's two main components. We need the exposure. We need these instruments to allow us to see what we're doing. And then on the right-hand side, we use the laser, which can be our cutting tool. And there's a few different ways we can use laser. That black contraption is called the MicroManipulator, and that can be actually attached to a microscope. And that little joystick on there we can use to administer laser. And then on the bottom, in the bottom photo, we can actually hold an instrument that has a laser fiber through there and use that to administer the laser to the area that we need to. These are just photos of an example of a vocal cord squamous cell carcinoma that was treated with laser. The middle photos is what it looked like right after the laser, and then the right-hand side is after a few months of healing. And I think I just wanted to highlight that there's other minimally invasive approaches to the head and neck. Our colleagues who treat sinus issues primarily do these surgeries, but we can even use telescopes and endoscopes in the nose and approach the base of the skull, which is the area that separates the brain from basically the rest of the head and neck. And there's pituitary tumors there. There's that anterior skull base, which is towards the front of the brain, and then infratemporal fossa, which is, you know, basically as time goes by, these endoscopes are able to access new areas. So this is also a very exciting area of minimally invasive surgery. I think that's it. So I'm happy to take any questions.
Thank you, Dr. Verma, for that whirlwind tour of minimally invasive surgery and head and neck cancer. I have some questions that have been coming in that not all of you can see. Why don't you use the robot for mouth cancer, like a cancer in the tongue or somewhere else in the mouth?
Sorry, I was muted for a second. Yeah, that's a great question. So the way the robot's really designed to go all the way back in the throat, so actually getting exposure and seeing the mouth is not so challenging for us if we're able to open your mouth. So it doesn't, I guess it doesn't add much in terms of getting the exposure because it's just easier to see that.
Got it. And then another question is, how do you know during surgery whether you got all the cancer out, regardless of the location, whether it's the oropharynx, the larynx, the mouth?
Yeah, that's very important to us. What we do is we remove the cancer of what we see with our eyes, and then we take margins basically 360 degrees around the tumor, so all sides and even deep, and send that to the pathologist and have them look under the microscope and make sure that they're negative before we stop. And that works with basically any site of the head and neck.
Got it. And then there's a question of how many of these surgeries are performed at Yale annually. I'm going to try and take a stab at that. It's a difficult question to answer. I mean, we like to break down cancer surgery volumes as high volume or low volume, and around the country. And Yale is definitely a high volume head and neck cancer surgery center, including robotic surgery, laser surgery, and even what Dr. Verma alluded to, more invasive surgery. You're hearing about minimally invasive surgery, but the truth is some patients, and some of the patients I'm seeing here on the chat, didn't have the benefit of the minimally invasive surgery and the treatment deintensification, and they had more invasive surgeries. So I'd say hundreds a year of head and neck cancer surgery are performed at Yale. Another. And then there's a question about how do you decide?
I'm sorry, Saral, can I make a quick comment about that? Because I'm not a surgeon. So it's not like I'm tooting my own horn, but in the national study of using transoral surgery for oropharynx cancer that's HPV related, not only were we one of the top accruing, had a very high number of cases that went on, but the surgeons at Yale turned out to be much better at identifying patients who were appropriate for transoral surgery and had a very low, or I actually think no complications that had to be reported on the study. So I'm not a surgeon, so I can say this, but these guys are phenomenal and they do a lot of it and they do it really well. Guys, obviously including Dr. Verma.
Yeah, we're half and half, so we're good.
Thank you.
We
That's very kind.
Thank you for saying that. I should have planted that one. Great. There is a okay, great. So some comments in there as well. Okay, well, thank you very much, Dr. Verma, for that. So now we will be hearing from Dave Zirlen, who is an expert in speech and swallowing rehabilitation for patients with head and neck cancer. So Dave, take it from here.
Great, thank you, Dr. Mehra, and Dr. Verma and Dr. Bhatia also. Thank you for inviting me to talk to you guys. It's a great thing to do. Let's see if I can get this to play. Maybe. Sorry about that. There we go. Okay, can everybody see that? And they can hear me? Excellent. Okay, so today I'm going to talk about what I try to do to prevent some of the speech and swallowing problems that occur from Dr. Bhatia and Dr. Verma curing people's cancers. And so there's some secondary things that happen just from the surgery or just from the treatment of the radiation that I try to, number one, prevent, and number two, try to fix. And that's the values. So we're going to go over a couple of things quickly. We're going to look at the normal anatomy of normal swallowing and speech. We're going to talk about the effects of that radiation has on swallowing and speech. We're going to look at the goals that I have and that I hope the patient has when they come to see me for swallowing and speech, and also talk about prehabilitation of swallowing. We'll touch a little bit on total laryngectomy, so that's when the larynx is completely taken out, and how we get people to be able to talk after that. And we'll talk a little bit about trismus, which was mentioned earlier, and that's the inability for people to open their mouths. So again, this is the anatomy, and I kind of look at it a little bit differently than everybody else because I have to look at how it functions and how it works for swallowing. And so basically what I'm showing this picture to show you is that there's basically a valve, and that valve is called the larynx. And that valve is there. The primary reason we have the larynx is to be able to protect our airway, because getting air into our lungs is very important. And so there's one tube that starts up at the top, comes from your mouth, and then all of a sudden it gets down into two tubes, and there's the esophagus and the airway. And it's good that only air goes into the lungs and only food goes into the esophagus. And so the larynx is basically a set of three valves: the epiglottis, the true vocal folds, and the false vocal folds. And those are all there to try and protect the airway, so that when you swallow, food doesn't go in there. So it happens very quickly, in less than a second. And what has to happen is that when you take the food into your mouth, you make it into a little ball. We call it a bolus. And then you take that bolus and you push it with your tongue against the roof of your mouth, and you trigger a swallow. Once you trigger the swallow, that epiglottis, which is sits up high over the airway, it gets retroverted and it gets flipped over to protect your airway, to close off the airway. And then the esophagus opens, and then the food gets pushed over the back of the epiglottis into the esophagus. And all of that has to happen in less than a half a second. So you can imagine if you had a big gulp of water or a big gulp of beer, and you're trying to drink it down, that has to happen all at the same time. And if somebody comes and cuts something or cuts a little piece out, or if somebody does radiation and it affects how it moves, then that's not going to work as well as it could. And so my job is to make it so that it does work as well as it could. And if it doesn't, how we can try and fix that to make it work better. And so this is a little X-ray. There's two ways for us to evaluate swallowing. One is a modified barium swallow evaluation, and one is a fiber optic swallow evaluation. And so this is just a quick little clip of a modified barium swallow. And if you look at the really dark bark material in the picture, that's the barium. That's the contrast that we give somebody to eat or drink when they swallow. And looking at this picture, the chin is facing the left, so the person is facing to the left. And there's a tube right in the front. That right there is the airway. And so you can see it's pretty big. And we don't want any of this black material to go down in there. So the epiglottis, which is just below the chin, where you see a little bit of looks like Italy, like the boot of Italy a little bit. And that's the barium coating the epiglottis. So I'm just going to hit play and let it play a little, kind of go over a couple of times. And you'll see how quick this happens. And it just gets where you saw that boot, it just flips over upside down and gets pushed down into the esophagus. Okay. And so this is a very similar picture. On the left, we have a picture of the modified barium swallow. And if you look, there's a little string-like tube thing in there. And that's actually an endoscope. That's the fiber optic swallow. That's the other way we can evaluate swallowing, is with a little endoscope. And if you're here and you have head and neck cancer, definitely Dr. Mehra or Dr. Bhatia has put that little scope in your nose, most likely, to look down there. And so in the picture on the right, the white is the barium. The barium is actually white. It shows up black on the X-ray. And so now we're looking straight down into someone's larynx. I call it the lion tamer's view. So if you open the lion's mouth up and stick your head in and look straight down, that's how we're looking down into this person's throat. So the front of the body is at the bottom and the back of the body is at the top. And you see a V there. The V is the vocal cords. And at the open end of the V is the back of the larynx. And right behind there is where the esophagus opens. And it's always closed unless you're in the middle of swallowing or if you're burping. And so we can see how that epiglottis is preventing that barium from just trickling over and going into the airway, and it's flowing around to a space we call the piriform sinus, which is one of the gutters of the larynx. And so this person hasn't swallowed yet; they have a delayed swallow, and that's what we're looking at right there. So when people come to see me, if they come before they're going to have surgery, if they come before they're going to have radiation and chemotherapy, we're going to do a swallowing test. And we most likely are going to do a fiber optic swallow, but we do a modified barium swallow sometimes as well. And so the effects of radiation, so the primary reason you're getting the radiation is to get rid of that cancer. But there are some side effects sometimes. And some of those side effects are reduced movement of all the muscles and all the structures. Sometimes while you're going through the radiation, you can have reduced movement because there's pain. And when something's in pain, you don't want to move it quite as well. There can be changes in anatomy from the surgery. There can also be changes in anatomy from the radiation. If the radiation is in that epiglottis and the radiation therapy takes away some of that cancer, takes away the cancer, it can also take away part of the tissue for the epiglottis as well. One of the other things that can happen from radiation is xerostomia. It's a fancy word, basically means your mouth gets very dry. You can get dysgeusia, which is a change in taste, and then you can get reduced vibration of the vocal folds. So the vocal folds vibrate like a guitar string kind of, and it has to be able to flow. And if things get a little stiff in your vocal cords, then you will get that same vibration. The goals of when someone comes to see me before they have surgery or before they have radiation, my goal is for them to maintain an oral diet through their treatment and to return to a regular diet after treatment. So when someone's going through radiation, I'm going to see them all along through their treatment, making sure that they keep eating. And the way we do that is why we do something called prehab or prehabilitation of swallowing. And so I tell my patients this sometimes, and I shouldn't be saying it now because I have Dr. Burtnish and Dr. Bhatia here, but I usually say the radiation department doesn't like when I say this, but radiation therapy is a little bit like a microwave. And if you took a nice piece of steak, put it into the microwave and hit 2 hours, you can imagine when it came out, it's going to be dry and stiff. Now, I also tell them that, you know, the microwave is $60 and the machines that Dr. Bhatia works with are probably $60 million. So it's not exactly the same. But if you can imagine that while that microwave is cooking that steak, you could stick your hands into the microwave and you could keep moving it, then it's when it's done, it's going to be more flexible and more pliable. And so by me giving you these head and neck prehab, these exercises to do through your treatment, it's going to keep everything moving and more flexible. So we're going to give everybody range of motion for the neck and the shoulders and the jaw. There's muscles called sternocleidomastoid. They come all the way through here. So if the radiation field is in there, we're going to give you these exercises to do 5 times a day on a schedule throughout the day, so that the radiation gets put in you in the morning or whenever, and then all day long, 5 times a day, you're stretching and moving that tissue so that it stays flexible. We're going to give swallowing exercises. A couple of the swallowing exercises we have are something called an effortful swallow. The effortful swallow is, imagine if your spouse goes, you ask your spouse for a peanut butter and jelly sandwich, and they go into the kitchen and they can't find the jelly. And so they take a peanut butter and they just make a peanut butter sandwich. But you don't know that. They come out and give you the sandwich and you take a big bite and it's all peanut butter and white bread. Well, how do you get that through your mouth? You have to do an effortful swallow. You have to push really hard with your tongue and swallow really hard. And that's an exercise we'll have you do so you can keep that tongue moving and keep the swallow moving. We'll give you a Masako maneuver, which is where you hold the tongue between your teeth at the front of your mouth, and then you swallow hard, and that makes you push the back of your tongue really hard. So you can imagine that pushing that food back over that epiglottis when you do that exercise. And then the Mendelssohn maneuver is where we get the person to stop right in the middle of their swallowing and hold it up there. And that helps strengthen the larynx that gets pulled up and forward, which retroverts that epiglottis, and that gets you to practice holding that. We'll tell people to continue to eat a variety of flavors and a variety of foods, because the radiation and the chemotherapy can affect the taste buds. And if we have you trying to almost do therapy on those taste buds by having different flavors all the time, that will help you keep the taste buds a little bit longer, or at least get them to come back a little faster. We have some pearls of wisdom that I tell almost everybody. You have to eat some solid food at every meal. So if it gets so painful that you can't swallow, you don't want to swallow solid foods, or it hurts to swallow solid foods, you have to have a bite of something solid so that you can get your tongue to push the food back and get your esophagus to squeeze the food down. We're going to have you do the exercises 5 times a day, as I explained before. When you want to do the exercises the least is when I need you to do them the most. So you can imagine if your neck is getting stiff and it hurts when you go to stretch it, well, that's when I need you to really stretch it. That's when I really need you to work on it. And then we work with the doctors about pairing the timing of the medications so that you can take your medication, have it be working as best as it can, and then you eat, and then you do your exercise. One of the other things that we do is we work with some people that have had their larynx taken out, and the trachea gets turned to the skin and creates stoma. So the person breathes in and out through there, and so then they don't have vocal cords anymore. So what we do is we put in a little tracheoesophageal prosthesis, which you see there in the middle, and that allows people to talk after they've had their larynx taken out. We can also give them an electrolarynx, which they hold on their neck or in their mouth. And then we follow them throughout to maintain their tracheoesophageal prosthesis for life. And the last thing that we talked about, which we talked about earlier, was trismus, and that's the inability to open your mouth. And so what normal mouth opening is about 35 millimeters to 55 millimeters, which is about 1.5 inches to 2 inches, depending on how big a mouth you are. And so if people have difficulty opening their mouth from the radiation, we'll use a device like this called a TheraBite to try and help you keep your mouth open through after radiation and after surgery. So that's what I have for you. And I will end my sharing.
Thank you so much, David. Really appreciate that. So hopefully the participants here can see that, head and neck cancer treatment, really, it takes a team. Surgeons, radiation, medical oncologists are the doctors involved that you meet, but there's also radiologists who are physicians, pathologists who are looking at the pathology. It's a whole team, plus rehabilitation specialists like David. And then we have a comment talking about a lot of the other complications that can happen as well. And unfortunately, some people do have significant problems with lymphedema, shoulder movement, neck movement, where we need physical therapists, we need lymphedema therapists, and a whole team of rehabilitation specialists. It can be very overwhelming for patients, I think, after being treated for cancer to deal with this. But basically what I tell patients is that there are 3 phases to their head and neck cancer journey. And it's usually the surgeons who are meeting them first and diagnosing patients. But I'll say first, we need to collect all the information. A lot of tests to go through, and biopsies and scans and consultations, and even prehab, and getting information. And then this can be the most frustrating part, I find, for patients, because they just want to get on with their cancer treatment, and they might not understand why things are taking a few weeks to get all this set up. But that's phase 1, collect all the information. We'll usually present at a tumor board, and then we'll do phase 2, which is the treatment. And you heard a lot about that already, with either surgery or radiation or chemotherapy, or many times a combination of those. And then part 3, and this is what I think the last comment is talking about, and Mrs. Smith just commented on as well. Phase 3 in this journey is surveillance and rehabilitation, where we see patients on a regular basis, or we make sure they're being seen by someone at least on a regular basis for years to come, and rehabilitation. This is the speech, the swallowing, the side effects of all the treatments. And as Mrs. Smith pointed out, also the mental rehabilitation is important here. So a lot of the patients here I see logged in, I think, are in that phase 3, the surveillance and rehabilitation. David, I have a few questions for you about rehabilitations. How do you decide who will benefit from rehabilitation after cancer treatment? Who does benefit?
So anybody who's having any kind of speech or swallowing problems would benefit from it. And also anybody who's going to be going through radiation therapy. So whenever we have someone with radiation therapy, we know that the most important thing is to do this prehab, this rehab before you get the problem. And those people benefit the most according to all the research that they've done.
Great. And in this comment by Ms. O'Brien, she comments on resources available. And yeah, it's, you know, we could always use more. And I think every disease team will say we could always use more in this surveillance and rehabilitation phase. And, you know, we keep fighting for it and hopefully keep making things better, basically, because we need you. There's a question about differences between rehabilitating from surgery versus radiation. David, any comment?
Sure. So when you have rehabilitation from radiation, they focus it as narrow as they can, but it has to go through the skin and through a bunch of other tissue to get to where the cancer is. So there's a little bit of a wider sphere of damage that can happen, and that's why we have you to exercise all those muscles. When we have a surgery that just affects the base of the tongue or the tip of the tongue or one side of the tongue or one part of the larynx, then we have to work on using the rest of the anatomy to take over to help that, to strengthen the rest of that anatomy to take care of the missing anatomy.
Great. Trying to see through any more questions. Are there any more comments from any of the panelists? Anything you think people would benefit from hearing? I think that was a really comprehensive discussion. There's so much more we could talk about, and we'd be happy to. But I think, you know, we wanted to keep this to about an hour or so, and I think we're there right now. But there's still some questions coming in. Actually, now, okay, you know what? People are now opening up here. This is good. Let's see if we can. I think the panelists can stay on a little bit longer and answer some of these questions. So. For post-radiation mucositis, are there any treatment approaches that can help with that? Kind of any of the panelists can answer that. Dave, Dr. Bhatia, do you have any comments on that? Does salt water 5 times a day help? Or for taste, anything else for taste, David?
So I'll answer the taste question. I'll let the doctors answer the mucositis question. But the best thing for taste is to try and keep working those taste buds. So don't go and buy the vanilla ice cream, because the vanilla ice cream is the only thing that tastes good to you. Don't buy the quart of that. Go out and buy small little cups of vanilla, chocolate, strawberry, mint. You know, eat a variety of other different foods, any kind of vegetables, different kind of vegetables, because the more you try and activate those taste buds, even though they're not working, they're not tasting what they should taste like, you're trying to activate those taste buds. And if you keep trying to activate those taste buds, then they're more likely to come back.
Great. And is there any, Dr. Bhatia, do you have any comments on mucositis? And there's a question of, do you think saltwater gargles could contribute to loss of taste?
So I think the loss of taste is mainly treatment related. Saltwater and baking soda rinses are established in just, preventing mouth sores, helping to clear out the mucus, just keep the mouth clean. Additionally, we also use some other mucositis measures. So, as standard, we now prescribe gabapentin, which is helpful it's a nerve pain medication to just delay the onset of discomfort from mucositis. We use doxepin rinses or magic mouthwash. Both are numbing rinses to kind of help mask the pain and the discomfort. They in themselves can also cause some taste loss, but it's transient, but allows people to eat better or, swallow with less discomfort. So it's a variety of strategies all used at once. And then there's pain management with opiates that patients transiently need on treatment and eventually come off.
And of course, taste, saliva plays a big role in taste as well to get food all around the mouth. So loss of saliva can definitely impact taste as well, for sure. That's great. Dr. Verma, there's a question that I think you were probably best to answer. Is there anything to prevent fistulas after surgery? And maybe you could explain what a fistula is in case people don't know.
Yes, so a fistula, I mentioned it in relation to the robotic surgery, but anywhere in the head and neck, if there's a surgery that involves your upper aerodigestive tract and the lining where most of these cancers form, there's a connection that develops between that and the neck. And so what happens is that saliva can go from your aerodigestive tract into your neck. And sometimes we see it, at different stages of treatment. Sometimes right after surgery, we can see it if there's a drain and it looks like there's something cloudy in the drain. Sometimes it's later, it's higher risk for patients who've previously received therapy, particularly radiation therapy. But, sometimes even when patients present with cancer, if it progresses enough, it can also itself cause a fistula. So, but most commonly it's an effect of surgery with higher risk in patients who have had radiation before.
Is there any way to prevent it?
Any way to prevent it? So I think the things that we try to look at as surgeons is really optimizing nutrition and making sure that we do have surgical techniques as well to make sure that when we do closures and things that they're watertight, and even using additional layers of tissue to try to prevent leakage from happening. But nutrition is also very important there. And so that goes into the whole, if you're able to swallow, if you're, sometimes patients do need feeding tubes, so we need to optimize nutrition through that, versus if patients are able to swallow, really trying to focus on getting enough nutrition in your body that helps prevent things like that.
There's a question about lymphedema as well. Maybe Dr. Burton, if you want to comment on that. It's a problem that a lot of our patients deal with. If you want to comment, Dr. Burton, perhaps on that.
Yeah, so I think it is more common for patients who need multiple modalities, so surgery followed by chemoradiation. As Dr. Verma was mentioning, if you had a prior cancer and this is a reintervention, we do have lymphedema therapists who can work on both massage to sort of move the fluid out of the areas where it's trapped, as well as dressings to prevent it from reaccumulating.
Yeah. Okay, very good. I think the questions have kind of slowed down, and I don't see any private messages either with questions. So thank you everybody for joining, and thank you for the panelists for taking the evening and providing this. So thank you all very much.
Thank you.
Have a good night. Bye-bye.